Hi, my name is Michael Safir. I'm a reconstructive urologist with Align Surgical Associates in Los Angeles. I am board certified by the American Board of Urology, and today I would like to speak with you about one of my favorite procedures, which is metoidioplasty. Now, today does not take the place of a formal consultation. At that time, you'll have the opportunity to ask questions that are specific to you and get tailored answers. Today we're going to discuss a little bit about the operation, what to expect, a little bit about how the surgery is done. First, I wanted just to discuss what a reconstructive urologist is. Well, a reconstructive urologist is a surgeon who has advanced surgical training in the field of genital reconstruction. In my case, I perform surgical fellowships in female and male reconstructive genital surgery at UCLA and UCSF. Since 2017, I have exclusively performed surgery for the transgender and non-binary community and have performed over 100 metoidioplasties. So what is a metoidioplasty? Well, a metoidioplasty comes from a Greek word which together means to change the genitals by virtue of doing an operation. It's sort of a vague term, but in essence what it means is to create a distinct penis, to create a distinct scrotum, in most cases to tunnel a urethra so that it emanates from the tip of the penis, and in most cases, to close down the vaginal canal. Now, traditionally, all of these operations are done together in one setting. Some patients request that we not perform what's called urethral lengthening, which is when the urethra is brought all the way to the tip of the penis. Some patients may want preservation of the vagina. It's important to bring up to your surgeon exactly what operation you're looking for, because in most cases we can develop a surgical plan that is designed to be able to deliver on exactly what you want. So who is seeking out a metoidioplasty? Well, typically our patients are transmasculine patients or non-binary patients. Phalloplasty is an option for many patients. Some patients don't want to have a complex operation which involves bringing skin and fat from another area of the body and microsurgically putting it in place to create a new penis. This is an ultra complex operation that requires a lengthy hospital stay and some considerable possible complications. Metoidioplasty, in essence, uses your body's own tissue to construct a penis, to fold tissue to make the scrotum, and as I mentioned, to close down the vaginal canal. The way that we perform the operation, it can be performed either as an outpatient or with a short 23-hour hospital stay. If patients request it, we can typically perform a hysterectomy at the same setting. Over the years, patients have come to understand that the procedure can be done in multiple ways. Although most patients elect to have all of the elements of the procedure, that is the metoidioplasty, urethral lengthening, scrotoplasty, and vaginectomy. Some patients request that we not perform urethral lengthening and leave the urethra where it is. In that case, you'll be able to urinate sitting down, but will be unable to stand to pee. Some patients request that we not close down the vaginal canal. This is an easy part of the operation to eliminate. More recently, patients have requested the combination of being able to stand to pee, that is, to have urethral lengthening, as well as to preserve the vaginal canal. We have performed numerous of these procedures. It's important to understand that having the combination of urethral lengthening and vaginectomy may increase the risk of urethral complications, such as urethral fistula or the inability to urinate, in most cases in a temporary way, through the tip of the phallus. In general, metoidioplasty is a good option for patients who want to be able to stand to pee, but are not interested in penetrative intercourse. So what makes the operation possible? How are we able to create a penis? Well, typically our patients have been on testosterone for many years. If you've been on testosterone for years, you'll recognize that there are some specific changes that occur in the phallus. The head of the phallus gradually grows in size, as does the shaft. There can be an increased amount of skin surrounding the phallus. This enables us to have sufficient tissue to completely wrap around the phallus and sufficient tissue to be able to bring the urethra all the way to the tip of the penis. It's important that we identify any challenges on the road to surgery. One of the challenges we have is in regard to body mass index. It's important to have a realistic understanding of what the phallus will look like, particularly in the standing position. If there is abundant skin and fat surrounding the phallus and concealing the phallus, it may be difficult to create a phallus of appreciable length in the operating room. Additionally, any prior genital surgery or surgery to the lower abdomen, it's important to understand the implications of surgery in these areas, as they may impact on how the operation is done. After a thorough evaluation, it's important to tell us which elements of the operation you want and which elements you don't want. Do you want urethral lengthening, that is, to urinate from the tip of the phallus, or are you okay sitting down to pee? Do you want us to remove the vagina, or do you want us to leave it as it is? That is, vaginal preservation. Do you want us to create a scrotum? If so, we will place implants, if you want, 6 to 9 months after metoidioplasty. Do you want hysterectomy performed at the same time as metoidioplasty? Or are you going to have it done locally months in advance of the metoidioplasty? And then ultimately, are there any specific cosmetic issues you wish us to attend to? Your insurance company will ask for letters of support from mental health professionals as well as your hormone provider. In advance of surgery, you will need to obtain insurance authorization. Our office will help you with this. Since many of our patients live outside of the Los Angeles area, you will need some help arranging for your trip to the West Coast, both travel plans as well as safe and suitable housing for approximately 3 weeks after surgery. In advance of surgery, we will have you perform a minimal bowel prep and will provide you prescriptions that are necessary for your postoperative recovery. Now, with regard to the type of metoidioplasty, some of the terminology can at times be confusing. Some patients want a simple meta, and typically what this means is they want us to release the ligaments that are tethering the phallus in place. Typically, it is very difficult to move the phallus around because it is anchored to tissue underneath the skin. With a simple meta, what we do is to release this ligament to provide as much mobility of the phallus as possible. Additionally, we can wrap the entire phallus in genital skin to provide a cosmetic look such that it appears as a penis. This is in contrast to what's called a full metoidioplasty, in which we release the ligaments, but typically we also create a urethra that goes all the way to the tip of the phallus using some of your genital skin. Most patients request vaginectomy as well as scrotoplasty as part of a full meta. The operation that I perform is a type of full meta called a ring metoidioplasty, in which we use specialized genital tissue to be able to construct the urethra without the need for obtaining tissue from anywhere else in the body, such as the mouth. This, in most cases, simplifies your recovery, since there is only one area of the body that will require healing. We have made some important innovations in performing metoidioplasty to improve in outcomes. Some of the things that we've done involve advances in surgery to be able to preserve the vagina such that the vagina remains an organ that is suitable for penetrative intercourse. This requires a carefully mapped out plan, as well as careful consideration of what your wishes are for appearance and function after surgery. We have also developed methods of extending the length of the phallus through release of specialized ligaments that attach the phallus to the bone. These operations are very complex, and careful consideration needs to be given to the surrounding anatomy in order to guarantee a good result. Like any operation, there are complications that can arise after surgery. The most common complications that can arise after surgery in the short term are things like bleeding complications, poor wound healing, lack of early symmetry. One of the common complications that can occur in up to 17% of patients is called a urethral fistula, which simply means that urine is able to escape between the stitches on the undersurface of the phallus. Many of these fistulas are temporary and heal up in time. At the time of your original operation, you will have a suprapubic tube, that is a tube that is placed above the pubic bone in the lower abdomen that enters directly into the bladder. For approximately 2 weeks, the suprapubic tube will drain all of your urine. At that time, 2 weeks after surgery, we will simply plug the suprapubic tube and allow you to try to urinate through the phallus. This is called avoiding trial. Patients succeed with this with varying success. Some patients are able to urinate immediately from the tip of the phallus. Some patients have more difficulty. One of the reasons we keep you in town for 3 weeks after surgery is that we can modify the voiding trial if for some reason your healing process is taking a little bit longer. Most patients have the suprapubic tube removed painlessly in the office prior to their return home. At the time of your consultation, we can discuss the operation, preparation for the operation, as well as possible complications and stumbling blocks in the postoperative healing process. I hope that this video has been helpful to you. I look forward to speaking with you at the time of your consultation.